I'm not seeing the presentator. My goodness. Let me call him. Maybe he's meeting the the timeline. Wait me a minute. Oh, okay. Mhm.
Are we able to share the screen yet?
It's not the problem with sharing the screen. The one who's supposed to be presenting is Dr. SUAT DOGANCY, and he is not on.
I see.
That's the trouble. I give it to him. I want to give it to him a call.
Okay, Jay. What I would recommend is that maybe you and Jose can have a dialogue about complications that you've noticed waiting for SWAT, because he's on Turkish time.
Oh, gotcha.
Maybe you can have that conversation. Thank you.
Sure. To everybody, I'm KJ Nagrasheth. I'm one of the vascular surgeons here at University of Maryland. On the call today also is Dr. Jose Almeida and Dr. Stephen Abramowitz. They're going to be discussing on this topic. The topic today is complications of venous stenting. Now that it's happened, what do you do? And so anecdotally, I mean, I think all of us have done a fair amount of venous stenting in our careers thus far. I can tell you one of the most common things that I see happen is mal-deployment of the venous stent. Maybe it deploys too far or too short, and people have to extend, and then they have issues. I don't know if anyone else has seen other things, but that's the most common thing that I've noticed in my practice is the deployment system for some of these venous stents.
Yeah, I'd agree with that. The the main concept in venous stenting, unlike arterial stenting, is cover all the disease. So sometimes it requires long stent stacks to accomplish this. And at the inflow site, namely the common femoral vein, when there's disease there and it's not treated, that will be a source for a stent occlusion in the short term. So sometimes one has to extend the stent right down to the profunda femoral vein confluence, basically stenting the entire common femoral vein and allowing inflow from either the profunda or the femoral vein. Oftentimes the femoral vein is occluded and your only inflow is the profunda, so you have to really manage the landing of the stent so that the profunda is in continuity with the stent and no interruption in flow with any disease there. That's not often easy to do, but I would agree that that would be a stent mal-deployment, on the landing if you're stenting from above down, but basically on the inflow side.
I think along those lines, one of the important things to consider is the disease state you're treating and trying to preempt mal-deployment. For patients with post-thrombotic disease, very important that you pre-dilate. Oftentimes, if you don't pre-dilate the lesion, you end up with either a constrained stent or a lesion that doesn't necessarily respond to post-dilation well. Sometimes the stent can elongate or it can be caught in a lip, and instead of catching the very end of your disease state, it can retract back in front of a stenosis. And same thing can be actually true of a nibble lesion in terms of that deployment, really timing out where you want the end of the stent to be and isolating where that compression lesion is key.
Yeah, no, I absolutely agree with that. Predilation is so important for these chronic kind of occlusions, and nibbles are a completely different pathology. I see Dr. Dognasius on the call, and I think he's our speaker for today. So maybe we can get him to share his slides and we can hear what we should do with venous stenting complication.
Actually, now they let me do it. Okay. I apologize for being late. I just flight to Berlin. We had some delay. I just could come to the hotel. I apologize. So okay, now I think you see it, right?
Yes.
Okay. So I think you started already, but we will today talk about the complications of venous stenting, and one of the most important complications is, as we all know, that there is thrombotic complications. So I will mainly focus on thrombotic complications, and then we will discuss. It is not a long talk, but I think we will highlight some discussions afterwards. Let's start. How we deal with iliac venous stent thrombosis. Actually, I have no conflicts related to the presentation. As we know that if we have a stent occlusion, there are several reasons for this. So it can be like inflow related problems, anticoagulation related problems, or technical problems, but sometimes it can be a mixture of all, and it can be the combination of all issues if we have a stent occlusion. So we know that Dr. Stephen Black's group published this article several years ago. I think it's a good way of analyzing why one stent has been occluded. So if you look at this failure classification, we know that there can be some technical issues like nothing to related with stent. It can be an inflow issue, outflow issue. It can be a device failure, flow related problems. It can be either hematologic like dose related or non-dose related anticoagulation problem, and it can be a multifactorial issues. So related with this, we have to analyze all the related pathologies when we have a occluded stent. And timing of intervention and decision making is really good for it, because if we have an acute way of stent occlusion and if it is less than 2 weeks, we should first analyze why this stent occluded. It was an inflow related problem. Oh, it is closed. I don't know. The host has been changed now. The venous and lymphatic got the host, and because of it, I was closed. Can you give back to me? Yes. Okay. Thank you. Yeah. So as I mentioned, if it is less than 2 weeks, we should analyze first why this stent has been occluded. It was an inflow issues, or if it was an anticoagulation problem. And accordingly, because it is still fresh thrombus time, we can make some thrombolysis or thrombectomy. We can change it if it was an total endovenous procedure. Maybe if we need, we can change it to the hybrid procedure, or we can do recanalization. Maybe we can do balloon angioplasty, restenting, or we can make some extension distal or proximal according to the pathology that we identify. And if it is a chronic case, then I think sometimes we can recanalize it again, or maybe we can still change conversion to the hybrid procedures, and we can do balloon angioplasty, restenting, or maybe debulking related with this problem. I will show some cases of mine which I have done before. This was, as you see, that this was an inflow related problem. Then this stent has been used. And as you see in this case, this was, I think, one of the first cases which I, let's say, recanalized. I tried to make this recanalization with, let's say, Rotarex device, but you know that this system is just, you are creating a small hole and it's not that helpful. But mostly we try to reopen the stent by balloon angioplasty. And I think this type of older devices is not that good. And I'm very happy that Steve is with us. I think he has a lot of experience with these new style debulking devices. I think we will talk later on. But we recanalize this with balloon angioplasty and this mechanic thrombectomy device. And another problem here, you will see that a stent failure due to outflow. This patient was stented in another clinic. You see that the tip of the, let's say, wall stent was very, let's say, narrowed because of the stent characteristic. But the problem with this patient is that the left side and the cava is already also occluded. But unfortunately, in the center, they only recanalize the right side, put a stent below the occluded cava. So there is no chance that this stent can be stay patent. Then in my practice, I recanalized the left side and the cava, but unfortunately I couldn't recanalize the right side. So right side stayed still occluded, but I can recanalize the cava and the left side for this patient. But I don't know why they made such a decision. Just put a stent below the occluded IVC. So there is no chance that this stent can stay patent. And this patient has been, let's say, stent occlusion because of the cessation of anticoagulation. So I stented this patient more than 2 years ago. Unfortunately, due to some teeth problems, the dentist stopped the anticoagulation 2 weeks. And although I told him not to stop, but after cessation of anticoagulation, as you see in the picture, the stent is totally occluded, unfortunately. So for this patient, I could hardly go through with some sharp recanalization and made some balloon angioplasties because in my country, in Turkey, we don't have these new debulking devices. So that's why the only option, sometimes you do the balloon angioplasty. Although it's not, let's say, a good way of recanalization, but as you see here at the end, we could recanalize the stent again. So it is not as healthy as the previous way, but after still, let's say, after recanalization, this stent is still patent. But I think the cessation of the anticoagulation without informing the, let's say, us, it's a big problem. So the next case, which I will show you, is this is a stent failure due to a stent property. This was a cava biliac stenting. So you see that nearly from the heart to the both groin, we stented this patient. As you see, this is all wall stent. I think it's more 10 or 11 stents is in. Just after the procedure, you see that we have a nice recanalization. And after 2 years, the patient came to me with a pain while standing and sitting and with a venous claudication. When I take the case in the angio suite, you see that the tip of the wall stent was like a bullet, so it was very sharp. This was the reason that is causing pain. And wall stent, you know that the tips of the wall stent is very, let's say, soft. So the vena cava inferior mostly is crushing the this wall stent. And you see here that the left side was still patent, but right side stent and the cava is occluded. I could hardly go through the sharpened part of the IVC stent, and I made balloon angioplasties, and because of the proximal part of the wall stents is very sharp, there are wires causing the balloon bursting. I think it was more than 10 PTA balloon burst because of the sharp tips of the cava wall stent. And at the end, we could hardly recanalize it. You see that we with the small balloons, big balloons, even because in Turkey, unfortunately, we don't have larger balloons than 18 millimeters. So sometimes I use double balloons like this to gain more room. And at the end, we could recanalize again. So I made a stent extension at the proximal part, and you see that we could reopen the stent. And after 2 years, again, this patient is doing well. And we know this RevCore device. I never use it, but I think Steve can mention about it. They have experience as far as I know. This is a good, I think, device for debulking the occluded stents. And another one, I think, for this one is this For instant restenosis, another, let's say, debulking devices. So we need more, let's say, larger debulking technologies to recanalize such an occluded venous stents. As a take-home messages, dear colleagues, we should respect the inflow and outflow. If there is no inflow and no outflow, we shouldn't stent those patients. And we should follow up our patients at regular intervals, because most of the time, since they get used to living with such painful legs, they don't recognize if they have some stent-related issues. That's why we should alert them any coming back symptoms. And anticoagulation is really crucial, so patients should be very closely monitored. And we should be also careful about any intervention that needs cessation of anticoagulation. And we should also be careful about the stent properties, like the type of the stent, size, radial forces, landing zone, and deployment technique. And thank you very much for listening.
Thank you very much for that insightful talk. We appreciate it. Dr. Almeida, do you have any comments?
Yeah, it's nice, nice cases, and it showed a lot of the pitfalls that we see. Um, wall stents, we're not using them that much anymore, but that's all that we had for 15 years. And as he showed there, the ends of the wall stents have low radial force, so they tend to taper down at the ends. And then when you're trying to reopen these and balloon them, yes, the balloons will catch on the stent braids and fracture the balloons. Some of these Atlas balloons, I've actually had them detach from the deployment system from being caught on these, on the wall stents. You got to go fish them out. So, I mean, I think he highlighted all the issues. It's inflow, outflow, it's anticoagulation. Stent properties definitely make a difference. I think the newer generation stents, the laser cut nitinols, are a little better than the wall stents for this indication. And the RevCore device we've used, and it is a much better tool because you can actually remove that collagenous tissue that lines the stent walls when they occlude. When you just recanalize and do hyperinflation with a balloon, you're basically plastering all that collagenous tissue to the stent wall. And if you have to reline with a new stent, you're going to lose a lot of lumen. So maybe one relining you can get away with, but a second one you won't get away with. It's all you have is hyperinflation, and the RevCore will get that stuff out. You do need to use the embolic protection device that comes with the system called the Protrieve. It sits in the vena cava. It's a mesh type funnel, and it will capture all the embolic material that you're showering with the RevCore device.
Dr. Abramowitz, have you used the Recana device?
Yeah, I have. Similar to RevCore, it's designed for in-stent fibrosis and debulking. Different from RevCore is its mechanism of action. So while RevCore is more orbital in its function, the Recana device is forward cutting with a sharpened blade on a coil that can expand on its distal end. Again, a different mechanism of action, and also successful in removing in-stent fibrotic material.
Great. Any other comments we have about this? I mean, I think that was a great talk, and very hard cases. These are all very challenging cases in general, especially ones that are chronically occluded. Is there anything anyone would have done for that right iliac stent that was landed shy of the vena cava?
Yeah, it looked like it was shy of a caval stent, not the vena cava, correct? Looked like it was jailed. So recanalizing the right iliac stent would get you to a vena cava stent, and you'd have to do some type of fenestration, so piercing it, ballooning it, and do a stent fenestration to get it open. But yeah, it looked like it was jailed, which is a no-no.
We had talked about inflow before. When landing up to the profunda and femoral confluence, What is the preferred approach? Is it from lower down from a popliteal axis, or is it from jugular axis? What are people doing?
I think
Actually, yeah, you go first, Steve, then I can.
no, after you.
Actually, in my practice, most of the people, according to the GLI classification, has issues also the femoral vein. Like most of the time, it's type 4A patients. So anyhow, you need the flow from the femoral vein and the deep femoral at the same time. In my practice, mostly I stent the distal landing zone is just above the confluence of deep femoral veins. So I try to get the both flow from both veins. So accordingly, the access side, most of the time, if there is available, I go for mid-femoral access. But sometimes if there is no access, so we go to the popliteal vein. But for popliteal vein access, actually, it depends on actually mostly if you are using new generation dedicated venous stent, it's not a big issue. But if you will reach to the cava, and if you are using wall stent, then the shaft of the wall stent is only 75 centimeters. And sometimes it's not reaching to cava. You should be careful. Then maybe you need to come also from the jugular to deploy a stent for the caval part. But if you are using new generation dedicated stents, their shafts are longer, so even you can stent those patients from popliteal access as well.
I absolutely agree. And most of our practice is coming from a popliteal or a femoral vein approach. I think the one thing that we're able to utilize very frequently is IVUS to identify the profunda very clearly for that profunda femoral confluence. If you're not, or you don't have access to IVUS, I think a jugular approach can be very appropriate, and so that you can selectively catheterize the profunda if there is any concern or question in differentiating between large collaterals versus the actual true profunda. And I think knowing that the profunda is a dominant inflow vessel and so important to maintaining stent patency, again, any question, I think a jugular approach or some sort of additional catheterization is a great way to develop a landmark.
Yeah, maybe to add to that on the stent occlusions from from below, you have to pierce the stent cap right at the inferior aspect of the stent, is really where it seems to be the densest. We just did one last week where we used the power wire just to pierce the cap and then advance our system and then get the wire up from there. But you'll have to get creative when inflow is an issue. Sometimes the femoral veins completely occluded, like the one we just had last week. The profunda was not great, but that was the only inflow source. And in this particular case, I had access down in the tibioperoneal venous trunk, recanalized the femoral vein just to get to the stent cap. And then once we got there, we got through with the power wire. We dilated the femoral vein and then accessed the femoral vein once we had a channel from the mid thigh, because it's easier to work from there. So there's all kinds of things one can do, but what I like is to remain supine. So if you're going to do a popliteal access, it should be a frog leg popliteal, because once you put people prone and you got to go to the neck, I think it's a more difficult procedure to get more creative.
I agree with that statement. I actually do almost all my venous procedures in a supine frog-leg position because, I mean, God forbid you have an issue with someone having respiratory compromise or a cardiac issue. It's really hard to do CPR on someone prone. So that's just been my practice as well. What about anticoagulation? We talked about anticoagulation. What are people's anticoagulation preferences after these kind of long stented segments and recanalization procedures?
In my practice now, mostly I'm using only DOACs, but in my practice I prefer to use not single dose, but I like to use double dosages like apixaban. Mostly I use. Although it has been shown that adding the antiplatelet therapy is not an extra superiority to the newly published articles of Niels Kuhr. But I mostly use also aspirin for 3 months after stenting, especially if it has been KY iliac stenting. I mostly use apixaban and aspirin for 3 months together, and then if everything is okay, I stop the antiplatelet therapy and continue with only DOACs. But if the patient has a history of previous more than one, let's say, attack of deep vein, episodes of deep vein thrombosis, and or if there are any, let's say, hereditary anticoagulation problem, most of the time I go long time anticoagulation. I'm very, let's say, conservative about stopping the anticoagulation therapy, as long as if it is not a, let's say, nibble. I use long time anticoagulation.
Okay, so in the last couple minutes, how long does everyone else do anticoagulation for these cases?
You want to go, Steve?
Sure. If there any compromised inflow where I'm concerned, again, we're talking the 4A, 4B, or a 5, I keep them on anticoagulation, therapeutic anticoagulation, and an antiplatelet agent for life. If there's no compromised inflow for a lot of stenting patients, I'll keep them on a single agent antiplatelet agent and anticoagulation for 3 months, then a single agent antiplatelet agent. And I do surveillance. If there's any evidence of in-stent fibrosis or in-stent restenosis, then I will add something back on and monitor that.
And then we tend to, with these, again, the difficult occlusions, we would use enoxaparin subcutaneous injection for about a month, and then move on to the DOAC. And the one that we like is apixaban, the BID dosing. Some of these, and that's lifelong anticoagulation with the apixaban. I tend not to use antiplatelet therapy on these. But have been known on some of these thrombophilic patients to do double dose apixaban, 10 BID, for at least a few years till they've demonstrated that they can maintain stent patency, and then maybe drop them down to the normal therapeutic 5 milligrams BID.
Yeah, and I agree with that. In my practice too, I mean, I usually do enoxaparin if they've been having thrombotic issues while on a DOAC. Otherwise, I'll go to a DOAC, and there's been trials recently published showing that apixaban seems to have better efficacy for some high-risk patients as well than rivaroxaban. So I think that was a good discussion. In the last minute, thank you, everybody. Thank you for the great talk. Thank you for the discussion. This was wonderful. And please, everyone, join us on the 15th of April from 12 to 12:30 for the topic will be perforators, when to, when not to, and how to. It's going to be a great talk. Thank you all.